Okay. Good evening to all. I, on behalf of Indian Society of Cornea and Keratorefractive Surgeons, welcome you all in this wonderful webinar. We'll be talking about updating your operation theater for maximizing safety as far as preventing infection is concerned. Before we actually go into it, ISCRS would like to congratulate its president, Professor J.S. Titial, because he has now taken over as the chief of RP Center AIIMS, and that is a matter of pride for ISCRS and all of us. So, as I said, we have our president ISCRS, Professor Titial, with us, who is the professor head admin. Admin, can you mute others? Who is professor and head cataract, cornea, and refractive surgery services and chief of RP Center AIIMS, New Delhi. He has numerous publications and huge experience in the field of cornea and refractive and all the anterior segment surgeries, phacoemulsification. He has received multiple awards, including achievement and senior achievement awards at the American Academy and many awards at the AIOS, at the DOS, at various levels, had numerous orations all over the country in every state. He was the first Indian to have performed the live cataract surgery at ASCRS, and he has also received the most coveted Padma Shri from Government of India by the President of India. So we welcome our chief and the President of ISCRS, Professor Titial.
Thank you, Rajesh.
We welcome Dr. Rishi Mohan. He has done his MBBS from Maulana Azad Medical College in New Delhi, MD from RP Center AIIMS, DNB from National Academy of Medical Sciences, New Delhi, FRCS from the Royal College of Surgeons in Edinburgh, UK, MAMS from the National Academy again. He is a very well-known and accomplished cornea and keratorefractive surgeon. He has done his 5 months training clinical registrarship in phacoemulsification from Prince Charles IU, Edward, the 7th Windsor, UK in 1994, and was awarded the membership of the Academy of Medical Sciences, MAMS, in 2006. His academic awards are the Gold Medal and Certificate of Merit for the first position in Delhi University and the Best Resident Award of the RP Center AIIMS in 1986. He's held various positions in various societies and is a very prominent member and a very, very good speaker and a very knowledgeable person. We welcome Dr. Rishi Mohan. I guess he'll be joining us very soon.
Yeah. We also have with us the chairperson of Scientific Committee of ISCRS, Professor Namrata Sharma, who is also the Secretary of AIOS and Regional Secretary of APAO and Secretary Eye Bank Association of India, and Professor of Ophthalmology in the Cornea, Cataract and Refractive Surgery Services at RP Center AIIMS. She has numerous publications to her credit, various chapters in textbooks, has authored 11 books, and is a known academician, very much inclined towards teaching the postgraduates, and has been a part of numerous instruction courses, both internationally and nationally. We have a very renowned speaker with us. I'll request Dr. Rajiv to introduce Dr. M.S. Ravindra.
Dr. Ravindra needs no introduction, actually. He did his MD from AIIMS, New Delhi, after his MBBS in Bangalore Medical College. He has a fellowship in Vitreoretina from Shankar Nethralaya, a fellowship in Cornea from Rajasthan University, USA, Chairman and Managing Director, Karthik Nethralaya, Bengaluru, President of the Netrajyoti Foundation. He is the founding director of Jyoti Basic Vision Center, formerly Honorary Medical Director of Bangalore West Lions Eye Hospital and Cornea Grafting Center, 1984 to 1998, former President of the Karnataka Ophthalmic Society, former President of Bangalore Ophthalmic Society. He's a very, very, very well-known cataract and refractive surgeon. His videos online are watched by many people. He's a very good teacher, and I welcome Dr. Ravindra today.
We also have a very eminent person as the panelist, who is again an expert in the field which we are going to discuss today. He's a chairman at Shankar Nethralaya. He's the head of the Vitreoretina department, Shankar Nethralaya. He did his, Dr. Girish Rao, he did his graduate degree from St. G.S. Medical College in Mumbai, and then postgraduate degree from Medical Research Foundation, Shankar Nethralaya in Chennai in 1997. He has numerous publications in national and international journals and has been part of various courses, both internationally and nationally. He has won the FDC award from Maharashtra Ophthalmological Society and numerous other awards to his credit. And most importantly, he is a person who is, who is thoroughly into it, who knows in and out of how to, update your operation theater in order to make the surgery safe. So we welcome Dr. Girish Rao. We also have with us Dr. I'm sorry for that. We also have with us Dr. Ritika Sachdev, who is the Joint Secretary and come Joint Treasurer of the Indian Society of Cornea and Keratorefractive Surgeons. She is the additional director at the Center for Sight Group of Hospitals, and she is trained in cornea and refractive procedures. She is known for her not only for her academic activities but also for her surgical skills as well as administrative capabilities. So we welcome Dr. Ritika Sachdev, and I have with me my co-moderator Dr. Rajiv Mukherjee, and I am Dr. Rajesh Sinha. So we welcome you all in this webinar, and before we move on to the actual scientific session, I'll request the President of ISCRS, Professor Titial, to say a few words. Sir, you have to unmute yourself.
Sir, you have to unmute yourself, sir. No, we can't hear you, sir. Is sir speaking actually?
You can probably take his vote of thanks later, maybe. Something wrong with the ID.
I think he's speaking, but he's put it on this thing, so
Yeah.
you probably cannot hear what we are
Sir,
saying.
you are mute. Titial, sir?
No.
Sir, you are mute. Titial, sir.
हेलो सर, कुछ सुनाई नहीं पड़ रहा. आप म्यूट हो और अपना वॉल्यूम इंक्रीज करो. वॉल्यूम इंक्रीज नहीं किया शायद आपने अपना.
हाँ कर दिया.
So we are about to start the scientific session. So we just wanted a few words from you.
I've got some, official people sitting, but I can understand, the process we have started. I should go on, and I think the best part of our ISCRS webinars is learning from masters, and that gives us so much of important tips, points to our listeners. And once looking for a operation theater, I think that's the most important area for all of us to understand what would be the best way to maximize the safety in the operation theater. And this is a very, very appropriate topic for even for a corona time. So I think we're going to have a very good session and learn many things from our experts. Thank you, Rajesh. We can continue now.
Thank you, sir. So we begin the session, and I'll request Dr. Ravindra sir to share his slides.
Is that visible?
Yeah, it's visible, sir.
Good evening. I'm humbled by this great invitation from a great society. I fondly remember my teachers, Dr. L.P. Agarwal, Dr. Madan Mohan, Dr. S.S. Badrinath, Dr. Mukherjee. They're all my teachers, and what I am today is because of them. I thank Dr. Jeevan Titial, the chief of RP Center, Dr. Rajesh Sinha. Thanks for your, invitation and interacting with me, Honorary Secretary, and Dr. Rajiv, Dr. Rishi, Dr. Namrata Sharma, who is the Chief of Academics in this great society of ISC KRS, Dr. Ritika, and my friend Dr. Girish. Thanks for inviting me. And this is an informal talk. And I'm not going to be an academically rich content in this. I would like to touch upon practical points. I'll go through a couple of slides initially, and then I'll share my videos. And stop me when it's getting bored or when it is overdone. You can always stop me and ask me anything else. So we are all great surgeons. All of you are super surgeons, and then you need to have comfortable sleep at night after doing a series of operations or a surgery on a VIP. And rarely, very rarely, in spite of God's blessings on us, we do come across complications in form of infection, in the form of CHARS or whatever it is, which will bring you really down to the earth from wherever you're flying. So how do we avoid, how do we ensure maximum safety? Big hospitals have got their own protocols. We are all NABH accredited. We have excellent protocols. But India is served by small and medium-sized hospitals where these protocols following is very, very difficult. So I've been giving these lectures where a simple operation theater by one-man show or in a rural area, they can improvise in this. Look at this blade. This is a blade which is purchased, this new blade, and it was handed over to the surgeon, and that's a 500 micron blade, and that is the condition when the surgeon took it under the microscope, he saw like fungal growth on it. So when this is rich in fungus, but many times pores are there, you can't see the fungus, and if you operate on this particular patient with this kind of knife, and you'll end up in fungal infections on day one. So these are available in India, and how do we avoid getting these supplies? The entire operation theater has got compartments. Air temperature and humidity are the environmental compartments. Validations of various processes is extremely important. Cleaning protocols of the operation theater there are no standardized cleaning protocols. Probably there are as many cleaning protocols as there are operation theaters. Sterilization systems, microbiological surveillance. Can we achieve no sepsis and no TARS in any operation theater in the country? Should we do a fumigation? These are some of the questions that we can ask. And how many cases get the infection? We don't even really know about it. It can be isolated, one in hundreds of them, or it can be cluster. Same day you see a lot of them. It can be bacterial clusters, and it can be fungal clusters. So supplies are very important. What we buy and contaminated solutions. These forms a major, the supplies that we use in the operation theater form a major sector in fungal clusters, while in bacterial clusters, it's our own operation theater which is the cause for it. Poor OT hygiene and poor construction is one of the main thing in the operation theater. Everybody do not have to have an AHU, though NABH says we need to have an AHU, but we can have safety in spite of not having AHU. I'll quickly go through it. We are all familiar with this. That's our operation theater, how it is constructed. All items are on wheels. Any moment of the time, there should be nothing which is standing on the floor without wheels. Anything you take, it's including the dustbin that is there with the plastic cover inside. Dustbin has to be absolutely clean. It should be as clean as the table. You cannot have a dirty dustbin and a very clean table. And it's very easy to move all of them from one place to another. There should not be any stationary object standing on the floor of the operation theater. And that is the AHU that we have. Each operation, we have 3 operation theaters. Each operation theater has got an AHU. I've done a lot of work on AHU. It is roof suspended AHU. This is a very good quality AHU. What you should decide is the distance between the operation theater and the AHU should be minimum. So that is its entrance to the operation theater. That is the AHU, and it's hardly few feet there. This is very important because ducting inside, you cannot clean it. You cannot go inside and clean it. So you should minimize this. That's the air conditioning unit, and it supplies a cool air to the AHU, and then one is the return air duct. This is the supply air duct. And of course, the area has to be kept clean. You can see the net there. The birds, cockroaches, lizards, everything can go inside this, and it has to be well covered with a net so that birds will not go and perch themselves on the top of the AHU and supply unit. That is the fresh air inlet, and it has to be covered cold. It has to be covered by a net there. There's a net there so that the birds or insects or flies cannot go inside the fresh air duct. So this much of care has to be taken. In many other operation theaters, this care is not taken, and whatever air that comes into the HEPA filter will be highly contaminated. That's one of the causes for coating of the ducts inside with dust. So you can see the the AHUs are, and you spare the floor area. Floor area is totally spared by considering that. What is the most important thing is not only the, you should keep these monitors. They are very cheap. They are available commercially. In every corner, you keep one temperature monitor and the humidity monitor. The humidity is one of the important things. When the humidity is high, you have fungal and bacterial growth inside the operation theater. That has to be minimized. Any gadget that comes into the operation theater should operation theater is not a store for keeping anything, and whatever that comes inside has to be nice and clean, including the bags, purses, mobiles. These are not to be allowed inside the operation theater. This is the water treatment plant. Water has to be treated properly before it's supplied to the operation theater. So at the fag end of it, this is the supply. This is where we're going to scrub our hands. We cover it by a 4-inch by 4-inch gauze, thick gauze and cotton pack. The idea is not to filter it further. This water that comes from the tank is never sterile. It should be clean. It doesn't have to be sterile. But what it does is, by accidentally, if there is some amount of contamination on the lines, and at the end of the day, my staff open it up and inspect it and touch it and see it under microscope in bright light. If there is suspended particles there, that means some amount of contamination is somewhere on the line, and you will see it may be blackish or it may be slimy. So that has to be taken. The scrub area has to be very clean. There should not be any crevices between the tank and the wash area, wash bay and the walls. Many times we put a steel one, there will be a lot of space there. That space is very rich in fungus. So this has to be avoided, and nothing should be on the wall. Wall should be absolutely clean, and all the scrub things are on a separate trolley, which can be easily again moved. When you discard the gowns should be kept in a porous bucket so that the wet areas in the gown will not multiply organisms. The supply be anything that has to be looked at, especially the fluid that goes inside the eye. It has to be seen against light as well as through it, so that there are no suspended particles in it. And you should never put the BSS on a galley pot and keep it on the table. So whatever kind of environment you have, the particles will be settling down by gravity. And this BSS, this is a very common habit, especially in rural areas. They pour BSS into this and nurses draw with a syringe. This should be absolutely abandoned. This is the most important slide I would like to stress on. We use a lot of ampules and injections. The ampules, you cut the ampule. This accidentally I saw maybe a decade ago. From that time, this is a part of my slide. And a part of it, a glass splinter may go inside, and I saw a glass splinter in the bottom of the ampule. From that time, I stopped using it. What does it mean? You're going to draw this fluid and use it in the patient's eye, and a splinter is inside. Splinter has got a sterile surface which is inside and an unsterile surface which is outside, and the solution is contaminated, and you're going to draw it and put it to the eye, and that's a sure invitation for hazard. And yeah, any bottle that you use, normally we take a swab and smear it and then put a needle into it. And the spirit or alcohol, which is 75-80%, 100% alcohol should not be used. It should be about 80% alcohol. You pour alcohol onto the bung of the bottle and then wait till it dries up. It takes about 2-3 minutes for it to dry because of the water content. 20% is water. That is purposefully appointed to minimize the quick drying of the bung. You wait till then. The ideal time to wait is about 5 minutes time. Then you put your needle and aspirate it. These are the two things that I would like to say. This I'll be showing in a video. And one of the commonest thing is the tubings. We use a lot of tubings in the operation theater, and these tubings have got an unsterile area and a sterile area. They are crossing the limit of the sterile zone, and you see many times these tubings go outside and then get unsterile, and that it comes inside. So whenever these things are happening, you keep sterile tapes there, and you stick sterile tapes at the place where they exit or enter, and this is a good way to manage that unsterile portion will not come into the operation theater. I would like to beg everybody, do not use anything in the operation theater for performing a surgery without proper sterilization. I would encourage you to sterilize everything, but it has to be sterile. And if anything that's used for one eye, one eye should not be transmitted to another eye. Whether it's gown or gloves or instrument, a diathermy probe or a diathermy cable or a phaco tubing, phaco tip, phaco sleeve, anything that is used for one eye should not be transmitted to another eye. Shankar Nethalaya and all major hospitals, maybe All India Institute, they have these compatible, but because of encouragement by trade, most of the many hospitals, I wouldn't say most, many hospitals reuse the probe, reuse the tip, reuse the phaco probe or a diathermy probe, and that should be, you should encourage habits wherein they have to change for every case. The patient-related factors can be excluded by proper draping and in covering of the lashes. Documentation is very important. Your sterilization, everything has to be documented. Look at the tube. This is one of the silicone tube that was being used and are not dried properly. Drying is very important after cleaning the any instrument, and you see the fungal elements growing inside. So if this is used, either the fungi spores themselves or the endotoxins from the fungi and bacteria are sure to give rise to problems. And I'll cover this up in a video. And the bins are out. Bins are not to be used in operation theater. And the packs, I'll show some of the videos of how to make the packs. And this is one statement I always like. It's going to be cleaned anyway. We just dirty the things that we have removed. Sometimes we wipe our feet, wipe our shoes, and we feel that anyway it's going for a wash, so let us dirty it. And anesthetists especially are, handle the mouth, and and all these things are absolutely dirty, and everything has to be, after general anesthesia, the whole OT has to be cleaned with its own cycle, its own laryngoscope, patient's mouth. They have a lot of bacteria, and we'll have to be very careful in preventing the contamination. The stores is another important area where everything has to be purchased in boxes. Don't buy loose, and those boxes are kept in a separate bay, which is insect proof or fly proof, and this bay is meant for operation theater. But when it comes to the operation, this is the operation theater store, and outside boxes are not brought into it. The food grade plastic or stainless steel plastics, like these are syringes which are stored in a box. The outside box will not come into the operation theater. That's the storage within the operation theater. Whenever you buy anything, ensure that there's no wet marks, there's no tearing of. This is actually a pack of drapes. Inside drapes may be very good, but they're contaminated. So moth-eaten or insect-eaten, these are all possibilities, and this will bring a bad name to the operation theater. Surprise visits at odd times, at night time, or when you're not operating, those days you get into the OT and see what's happening there. Yeah, I'll share some of the videos. Are there any questions for the lecture that I had given just now? Is that visible now?
It is visible.
Yes. Yeah.
Just like to know, for the interest of the audience, why are we propagating 70% isopropyl alcohol and saying that do not use 100%?
Yeah. See, the reason is that when you put 100% alcohol, there is a duration. There's a wet contact time for alcohol to, it will not sterilize, disinfect. The load of bacteria or comes down, vegetative bacteria comes down when you apply alcohol. If you put 100% alcohol, it evaporates immediately, and the duration is not met. If you mix with 30% water and 70% alcohol, the mixture remains on the bung or wherever you applied for a longer time. So the ideal contact time to maximize the effect of alcohol is about 5 minutes time. So we put couple of drops there and leave it there for some time and do something else. And 5 minutes later, we come back and draw that fluid, especially in the vials where you're going to take it directly into the eye. For example, the anti-VEGF injections or like for example, if you're using any vial with a bung on it and if you're drawing it into the eye, I'll show you a video as to how to do it. And the wet contact time of 5 minutes is very important to maximize the safety.
Thank you.
So that's a video. Our country is full of dust and dirt. As any person who walks inside, there should be a dedicated area here. This is not a toilet, this is a clean area, and soap is available there. You have to clean this is an OT technician. He has to clean after putting Dettol on the floor, rub on the floor, and he has to clean before he enters into the operation theater. So this is how this video was taken after Rajesh told me that I'll have to present something. Currently, I've scrubbed and come here. The hand has to be wet, and the direction of the arm should be in such a way that the fluid drips, and maybe if it drips down here, and not this water should not come there. I scrub for 10 minutes initially for 10 minutes. That's the first scrub, and after that, between cases, I scrub with alcohol. Earlier, I used to scrub for every patient. That's what Dr. Badrinath taught us, but that it takes a lot of time. So I've walked into the operation theater. He has handed over. This gown is folded inside out. So outside area, I'm not touching at all. I am wearing it in such a way that my hands, which are clean, but they're not sterile. But the gown is sterile. The hand should not touch any part of the front of the gown. And now she's going to give me the first glove. I'm holding it in such a way that the outside portion of it is not contaminated my right hand. And then now I'll take the other one because I wore the glove, and see how I'm holding it. Again, this glove hand should not touch the bare naked hand. So that's the end of it. And this is very important when you're wearing it in such that you always separate the clean area from sterile area. Clean is not sterile. So the two should not touch each other. I'll just show one video of how do I drape the eye. She has given me, I'll just run through for the sake of, that's a drape. And somebody lifts it up. See that your glove is not touching anywhere. This is very important. You should be very conscious of the sterile area. I'm draping it many times. The nurses do it. They're aware of it. And that's a green tube which is creating a vacuum here. That goes into the suction, the return air duct, and that continuously removes air that is coming out because of COVID times. We are very strict. And again, you see that when you're encourage the patient to open the eye fully, and sometimes I show my hand to guide her as to where to look at, and that's the one which lifts the drape up. And this drape is enough. We don't cover the entire body because some hospitals will have cover the entire body with a sterile drape, but we are happy with a short drape like that, which measures about 120 centimeters on either side. I'm reading out the patient's data, identifying the eye and the patient, and tilt the head towards me so that there is a general gravity which helps minimize the thing. These have to be changed for every case, but we have developed a system. I don't even touch anything. He sets it up, he sets the arm, I'll start my surgery. And I'm not touching the microscope, but if you're touching the microscope, you'll have to remove and change the handles for every case. So that's how we start the surgery in our hospital. You can stop me anytime with a question if you are. This is the trolley setting, very important, and you just watch it carefully. The trolley has got a plastic sheet that is put on it. Plastic sheet is etio-sterilized, and it will minimize the chance of fluid in case the fluid drips down and goes to the stainless steel. You cannot articulate the stainless steel, but trolley sheet on the top of it, which is plastic, prevents that contamination from the steel trolley. So she is a scrub nurse, and after he opened up the first wrap, and he is going to give handover. Every supply should be peel open type of supply. You lift it up So when you buy the products, you should be very, very careful that the peel open type of supplies are the ideal. Now again, she is showing the way. The gloves I'll just run through. I've already covered it, and that's the inner one, which is sterile pack, and that's how it comes from the autoclave directly. When it is folded, you see many folds are on the top. There is only one fold at the top, bottom. So what we do is we keep it upside down so that there are many folds of cloth in the first pack and second pack, separating the outside to the innermost area. All these will have innermost signal tapes are there in this. And when I do an SICS, that's all the instruments I need. We'll come to the phaco later. We need very few instruments for the SICS. That's the advantage. There's no box there. And it's directly instruments loaded onto the silicon mats. So you can see the handing over. Even this is peel open type. I'm picking. Somebody picks it up from the top. He's not going to put it directly. And the viscoelastic is in a bottle. And there is an ampule of lignocaine. This is very important. I've already told you this ampule is sterile inside and outside. It is broken. It is sword inside, so that it's easy to break. She breaks it and draws into the syringe and keeps it ready. Nothing from outside is drawn into the operation table. And this is also easy to remove. And this is a lure lock type syringe. Visco is always loaded into a lure lock so that accidentally it doesn't jump out. The needle the cannula should not be jumping out. So I minimize the supply that comes from outside, and the contamination possibilities are least. Again, that's a peel open type of a drape. Now, how do we collect the fluid? We have devised in a way, the bottle is outside. There is a silicon tube, and he has bought the BSS bottle there, and it comes out through the IV set, and it comes into the IV set, doesn't come here. There is a silicon tube, and the tip of IV set gets connected to the cannula, and that is fixed there. And now the sterile fluid is collected into the silicon bulbs. This is how I do my SICS, and it's 100% sterile. Everything is sterile. So how do we wash? At the end of there's the end of the surgery, and all the instruments are cleaned here itself. The first cleaning happens here. Any lens matter, any cortical matter, everything is cleaned up. She discards it. Patient has walked out. She transfers them into a tray like this. Nobody is going to touch this, because in case the patient has got HIV or whatever it is, nobody is going to handle it. And that goes into the instrument cleaning area. This is a central holding area. That's our another operation theater. That's a store. This is where we do the painting before the surgery. And betadine wash just before the patient walks into the operation theater. That's the that is a scrub area. That's a sluice area. She's going to come here. The first thing that happens during COVID time is we used to put it in sodium hypochlorite for about 4 minutes time. So the entire, this is the previous surgery tray. This goes from here to here. This is not sodium hypochlorite. This is a mild detergent. It gets dipped in detergent. Then it goes to the anti-rust solution after this, and then it goes to the ultrasound cleaner. This we are not using it anymore because we are through the COVID pandemic, and that goes to the ultrasound cleaner. Then she cleans up manually every instrument. This is a separate team which cleans the instruments. This is an area, this is a wash basin, the quartz wash basin. What we have done is this is a submersible tank, submersible pump actually. This is inside distilled water, and distilled water comes Yeah, initially the washing is done with the running tap water. I'll spend a little more time here so that you can go and teach your. Uh, she cleans the entire thing with tap water, which is not distilled. It has some amount of salinity in it, and every instrument is unlocked, cleaned with a very special soft brush. And whether the instrument is used or not, this process goes on. She doesn't know what instrument we have used in the set. Lock it up. This is the most important. I told you about a submersible pump that continuously injects distilled water in it, and she just have to mount all the cannulas into it and clean it up. So that prevents a lot of they otherwise they clean with syringe. It's quite hurting to them at the end of the day. This really helps them in hastening the process. See, everything, all the cannulas get immediately cleaned. The timing is very important. The moment you have completed the surgery, the cleaning process has to start. Longer you wait, I mean, the bacterial growth inside will be occurring, and the particles can clog the inside and clean the inside of the tubings. These tubings have to be discarded periodically because ideal way to clean is with a brush. You obviously cannot go inside the tubings and clean it with a brush. And so you'll have to discard these tubings. These silicone tubings are not expensive. So you can buy 50 meters, 100 meters of this, and they'll change it up. How do they pack it? As I've explained to you, that's the way we pack. First closure, and I'll run through it. And then again, it's kept inside another cloth, and instead of cloth, you can use paper napkins. The best is to have paper napkins outside and the cloth inside, or both of them can be paper napkins. We use cloth for the sake of protecting the nature. We don't want to use a lot of disposables in our operation theater. We are very conscious of what we dispose in the operation theater. That's a Melag autoclave. And Melag autoclave has got both the flash setup as well as the full B cycle, B autoclaving cycle, but we use only B cycle. We never use flash autoclave in our operation theater because B autoclave full cycle is always better than the flash autoclave. That's a water supply to the autoclave. We have a horizontal autoclave, which is a B class autoclave, and that's got a nano controller. And these autoclaves have to be validated by a third party. The supplier should not validate them. Third party person runs the cycle, validates them, and titrates the number of vacuum cycles and heat cycles. Our autoclave has got 4 cycles of depurging. So that's how and it has to be periodically validated once in 6 months. These are the packs which are kept vertical to the direction of steam flow. Steam flows from the back of it to the front, and it has to percolate through every pack. Yeah, this is one of the most important thing. We have to have a system of validating every autoclave process. The tape, there is a special signal indicator which goes inside this plastic in the plastic tube, and that gets into, as you can see, he is going to screw, it's there, he's going to screw it inside, and this has to pass. For every autoclave cycle, we have to do the test. So the first thing in the morning, the nurse is going to check it up, whether the strip is completely black in color. It should be completely black in color, not gray in color. And then only we are going to start the surgery. The expiry date has to be written down depending upon the environment. You can have 1 day expiry, you can have 3 days expiry, or 1 week expiry. Expiry date has to be mentioned on the every pack. So that's how the packs, as you have seen them. And signal tapes are there outside as well as inside. This is in addition to the process control device, PCDs, that you saw just now. Tyvek pouches are often used in operation theater. You should have a impulse sealing. Don't seal with the commercial available heat sealant. It has to have a broad sealing, ideal to have 2 kinds of sealings. And when you put an instrument like this with it's got a sharp tip, you should be very careful. The tip has to be protected. He has not done it, and it's wrong. Tip has to protect. Otherwise, the sharp tip of it can puncture it, and later it can go inside, and that is unsterile. And we are going to take it to the operation theater. So the sharp tips has to be protected by a sleeve. So whenever we do a phaco surgery, we have done a B cycle autoclave running of the phaco trays, and this can hold 4 trays, but now you see the 2 trays, and we change the entire tray for every patient, every surgery, and that is brought out. And that's in addition to the common instrument set, we have the entire phaco set there. And now this phaco probe goes into the operation theater for the next surgery. It's again very important to maintain the cycle of asepsis and complete sterility when you do it. And this is a ETO sterilized plastic cover which covers the trolley, and then trolley is ensured that it doesn't slip off. A cloth there, and assembling of the phaco probe. And as you see, when you buy a phaco machine, ensure that the cassette can be autoclaved. Do not buy a machine where they say you have to buy a cassette for every case and you end up reusing it. So this is a phaco. I have no commercial interest, but this cassette can be autoclaved any number of times. That's very. If there are 5 cases, autoclave it 5 times. We have 4 sets. You buy 4 hand pieces, 4 tubings, and recycle them. So the entire thing takes about 5 minutes time. You have to invest just 5 minutes. And you see the water there. If you have not put a sterile plastic cover on the top of the trolley, this water area percolates inside, and the bacteria which is on the stainless steel will travel up here within minutes and hours, and it will unsterilize. And again, you'll have to earmark the unsterile and sterile areas of the tubings. Should I stop here or shall I continue?
Sir, I think you can continue. Dr. Rao, would you like to say something on this?
I'll run through the videos quite fast.
Yes, sir. Please go ahead.
Yeah, I think let him go through this. And then if you have any questions, we'll then.
Right. So at the end of the surgery, he's going to remove it, and the entire thing goes into the washing cycle. And we don't use any of them for the next surgery. And maintaining it, there is a cycle of how to do it. And now we have abandoned it. We run through the pump that I have told you. You should use a 50 ml syringe. And after every phaco surgery, you'll have to run it through about 200 ml of distilled water before the phaco probe is re-autoclaved. So how do we clean the vitrectomy probe? When you are done that's a vitrectomy machine that I use for my surgeries. And handing over the probe, which is autoclavable. This is a mid-lab probe which can be autoclaved and is handed over to the assistant to fix it to the machine. And surgery is over. At the end of surgery, I'm going to, the surgery is over now. We have used a vitrectomy probe. How do I clean it? Yeah, I take distilled water in it, in a bowl like this, about 50 ml, and cut and aspirate it. This fellow is coming. Yeah, you can see. I'll immediately. This has to be done immediately so that the dirt in the tubings is removed, and then initially distilled water, and then I dry it up. I suck air in it. Yeah, that's the settings I have. 500 ml 500 vacuum, and 150 is the cutting rate. So I'm sucking water into it, and it's supposed to clean the inside portion. After that, I suck air in it. At the end of it, I suck air. Then I aspirate the distilled water from a 15 ml distilled water bottle, and then I take alcohol in it and aspirate. The alcohol, 80% or even 100% is fine. It's going to remove all the water bubbles from inside, and then I aspirate only the air in it, and then it becomes really pristine, really gets cleaned. Then it goes into the autoclave. That's the packing before this. We have seen it, I suppose. I'll just go through it. It's very important to pack them nicely so that there's enough amount of vacuum happening, and these ends should be open so that inside of the tube also gets sterile by proper vacuuming. That's a tray for phacosurgery. How do we maintain the environment? Periodically, you have to do it yourself. Wherever there's a horizontal surface, like there's a horizontal surface here, horizontal surface there on the camera, you should inspect it, take a wet swab and run it. Tomorrow you can do it in your operation theater. You'll be surprised to see the dust accumulating on a white wet cotton. You have to identify, you have to, anything that this is a lens actually. I'm watching the lens of lens bottle. You can see fungal elements on the lens bottle as I rotate it. So it's a good habit to inspect whatever you use, whether it's anything that you use on the table. Just bring it under the microscope, inspect it under microscope, so you can see the elements there. Here, because I saw these elements, I'm inspecting the entire bunk, but normally we don't inspect the bunk, but at least the bottle, you can see there, the growth there. So you cannot use them. Mistake is not yours, mistake is the supply, but you will be penalized for that. Any bottle that you use has to be inspected against light, and it's important to see if there are any floating particles. OT cleaning is a very specialty structure. I'll just show you how we clean our operation theater. Everything is moved to one half of the OT. Because they're on wheels, it's very easy. Then the entire floor, the walls, and the ceiling is cleaned with detergent. What is best to clean? People clean with bacillocid, people clean with all kinds of antimicrobials, but best cleaning is by detergent. If you can obtain neutral detergent, it's better, but any detergent is all right. Neutral detergent are the best. And you don't have to clean them with any insecticides at all, any bactericidal agent. But what is most important, even if you want to choose cleaning it with bactericidal agent, you should have the initial cleaning with soap solution so the dirt is removed. Any amount of chemicals used when the surface is still dirty will not work there. First, remove the dirt and oil by using it, using the soap rather than the chemicals. So now he's going to use a 2-bucket system. The material that the OT is made of should be non-porous. We have vitrified tiles which is totally non-porous, and this gap of 5 millimeter between the tiles which is grouted with epoxy. So this makes it impervious. Imagine this is made of cement. Cement absorbs water. The water remains inside and promotes the growth of bacteria and fungi. So any material that you use for the stainless steel is a good material, vinyl is a good material, vitrified tile, glass, these are the material that your OT should be made of, and they should be totally non-porous. So he is going to clean the OT with that way, initially with detergent, followed by water. So I'll run through it. So cleaning protocols depend upon how quickly the OT becomes dirty. You'll have to devise your own cleaning protocols so that the area, the environment remains clean. Fogging is out. Fogging is not necessary at all. Surface cleaning with soap followed by bactericide in case you need it is the protocol that is followed by in most of the modern operation theaters. So an OT is made of spaces. This is a central holding area. That's one of the entrances. That's the OT1 that we have. And that's a cleaning area, the hand washing area. That's inside of the operation theater. I'll run through it fast. There are no crevices there. The foot control is there to for the water control. We don't have to touch the tap. This is an area where the sluice area, where the whatever cleaning material is all stored on this side. And these wash basins are not used to wash your mouth or nose. We should never use them for any such purposes. The water that comes out goes into an effluent management system, which has got hypochlorite, and then it is let into the general area. This is a very compact operation theater. We're actually extremely comfortable in running all the 3 OTs together. Yeah, I think that's the that's a small presentation that I could share with you all. And I'm willing to learn from you people, especially Dr. Girish Rao. I'm from Shankar Netralaya, and I've learned majority of this from Dr. Badrinath, and open to answering any questions.
Thank you, sir. Thanks a lot. Dr. Rao.
I think excellent presentation, sir, and you have really split it into various steps with videos. And for me, it was like a walk down the memory lane. So most of the steps that he's been doing was what Dr. Badrinath has taught us all over the years. Only thing is, I would like to highlight some of the differences that we have over the years now started, is we have now moved to most of the disposables. So we don't use linen now at all. So most of the drapes are the disposable drapes. So it's much easier to maintain. You're not worried about the maintaining the cleanliness and whether it's really being cleaned and dried and then got back to the operation theater without any dirt or anything else. And especially with a high volume, it's very difficult to ensure that everything is spick and span. So we go for the disposables. There is the cost involved, and I agree to your concern about the greenhouse effect also to it. But at the same time, the safety of the patient's eye is something of a concern for us. So we have across the system now moved completely to the disposables here. I just wanted to highlight some of the OT considerations in a single theater practice or a single person practice, how it differs from what a standard NABH operation theater would require. So you have now showed a very beautiful video of an NABH compliant OT with a separate single AHU for each OT, which is the most ideal. Though NABH right now doesn't insist that there should be a single AHU for a single OT. As per the 2018 guidelines, and that's more because of the concerns of most of the hospitals in India. So they do allow for an AHU to cater to more than one operation theater, provided you have a backup. In case there is a breakdown in the sepsis or sterility, you should have a backup of moving the cases to a different AHU, which has nothing to do with the AHU which is contaminated or under question. But coming on to the window ACs or the split ACs, NABH clearly does not allow this. So if you're looking for an NABH accreditation, you will have to go for a AHU. It will not accept a window AC or a split AC. But if you still want to continue with a split AC, it would be better to have a split AC with a microbiological filter, not the regular filters, which kind of just block some of the bigger particles, but not really the microbiological gate. So if you have microbiological gate filters, especially I think companies like Daikin and Hitachi do provide that. That could give you some kind of comfort that there is some way you're controlling the microbial load in the operation theater itself, though it's not nowhere in comparison to what a air handling unit with all the 3 filters, the pre-filters, microfilters, and the HEPA filters can provide. Coming on to the floors, the vitrified floors, again, you have to be very sure that it has minimum water absorption capacity, and generally, if it's a vitrified tile and you cannot, undo that, then you should ensure that at least it has less than 3% water absorption capacity. So you'll have to get that from the vendor, that this is absolutely non-water absorbent. Try and get as big a tile as possible, preferably 1 meter by 1 meter. So the advantage with that is you have lesser joints. Though you have very elegantly shown how an epoxy can be used in between to seal the joints and try and reduce the risk of the dust collection there or the cement wearing off. But larger the size, lesser would be the joints and lesser would be the thing. Also ensure that there is coving at all joints so that there is no sharp points where the dust or other things can collect. The floor should actually be as anti-static as possible. The doors, I think very important, must ensure that it's not a wooden door. I think it's an absolute no-no. If you have doors with automatic closers with sensors, fine. If not, ideally would be the stainless steel doors which close, which can be operated with a foot switch, so that you have a hands-free entry into it, and which when it closes can magnetically get sealed, so it's an absolute airtight compartment. That's the ideal situation. But in a given situation where you cannot have that kind of a high-end door, maybe the aluminum doors could be an alternative to it, because it's easier to maintain and there is no risk of a fungal or other microbial growth within that thing. But again, ensure that it has to be as airtight as is theoretically possible. Walls, I think the polyurethane coating, if not possible, then at least the antimicrobial, the antibacterial, antifungal coating on the wall, so that there is still some amount of a safety mechanism which is available there. Within the OT, as you rightly said, keep everything on the wheel so that it can be moved out and cleaned every day, thorough cleaning at the end of the week, whichever way you want it. There should be no projections within the, so basically it should be like a square or a box with no projections, no beams coming into the room. Everything which is very easy to clean, and there are no, as minimum joints as possible. Another strict no-no is no windows. No windows in the operation theatre. And if for some reason there is a window which cannot do it, then it should be absolutely airtight, sealed with double door, double glass, so that there is absolutely no leakage. So I think for me, the sanctum sanctorum of the hospital is the operation theatre. That's where the patient gets his biggest benefit within the organization system. That's where we could lose our years of reputation in the matter of a few days if there is a cluster or any event which is due to hospital-driven factors. So I think absolute no compromise in any of the safety mechanisms here. That would be my take on this.
That's very well said. And I can tell you a lot of people are being benefited by this discussion and by this talk. People are there on the web, YouTube and Facebook, and a lot of questions have come up, a lot of appreciations have come up. So definitely we'll take up a few questions from YouTube. There's a question regarding tiles. Dr. Rao, you were talking about tiles, and that's what Dr. Pradeep Agarwal wants to know, that tiles on floor with multiple joints. So I mean, this is definitely a cause of concern. So what precautions you have mentioned about that?
Dr. Sinha, I would like to just add here, when you want to buy the tiles, you have to buy full body vitrified tiles. There are vitrified tiles with half ceramic and half only top is vitrified. insist on full body vitrified. What he did was I took a whole tile, weighed it in dry condition, and then put it in water for 24 hours. And so in case there is any absorption, the weight will increase. Then I weighed it again. There should not be any difference. So that means no water has gone into the through the pores of it. The vitrified tile, the absorption is less than 0.01%, less than 0.01%. And Dr. Girish did mention it should be less than 3%, but it will meet much, much more than that. Vitrified tile is one thing which dries immediately. You put it water, you see that it dries in front of you. So tiles are all right, but they should not be paper joints. Like they join one tile to another tile, and they say it's sealed, but that crevice is permanent. You cannot seal that. So give a gap of 5 millimeter or 8 millimeter, whatever it is, and then fill it up with grout of epoxy. Epoxy is again waterproof. It's compatible with the operation theater surface. And then you will have a paper. And see, when you put flush with cement, if you put cement in between, cement is absorbent. Water gets inside. And it takes hours for it to dry. In that hour's time, every minute, the bacteria will multiply exponentially. You can't believe how fast they multiply. So it should be waterproof. That's whatever water, like stainless steel, polyurethane paint. For the roof ceiling, you can't put anything. We have stainless steel there, but polyurethane is a good substance because it again makes the surface waterproof.
Yes, sir. Thank you, sir. There's another question regarding the walls, actually. What they want to know that is it advisable to not to have walls with right angles?
Yes.
Because
Dr. Girish
in
mentioned
that
about
the
COVID.
dirt and dust can get trapped.
Correct.
So it's better not to have walls with right angles. Maybe we can have a facet sort of thing.
Yeah, so I think that's called as coving, and Mr. Dr. Ravindran's the walls. I think if you can show
You
one
can
of
see this is a vertical wall. Can you see the photo?
Yes,
sir. We
That's a
can see it.
vertical wall. That's a horizontal wall. There is no right angle here. It goes.
Yeah.
It's when you swab it, the entire surface gets swabbed. If it is a right angle, the corner of it will accumulate dust, and your cleaning material will not go into that. It's there. And even here we have put a triangular one. And this is a duct, air duct, return air duct ducting, and this is also there is a window here. Dr. Girish Rao did mention about the window, and we did just to save light. We do have windows, but that is covered by glass cassette, which has got vacuum inside. There is a vacuum in between. There are two glasses. These are commercially available. They make it, and they fix it with silicone sealant, and it should be flush with the wall. There should not be any space there. The glass should be in flush with the sort of the wall. There should not be any scope for dust to settle there.
Just a word that the coving should be of either the epoxy or the polyurethane. The coving should not be against cement. Otherwise, again, it can collect the water.
Yes.
There's another question regarding the precautions taken in Operation Theatre. And during the COVID times, we had so many guidelines. We used to take all those precautions. Many things have gone now, when people are not no more using the goggles, or no more using the face shields and all those things. So now currently, what are the things that are additional things that we have learned from the COVID pandemic? Like we in our OTs, we still are wearing double mask, and one is N95, etc. So I don't know what I would like to have opinion of both of you and others also, that what additional things are what have been added because of this COVID in our Operation Theatre safety norms.
Dr. Girish, you would like to comment?
Yeah, so I think one of the first things that we did was to have the UV lights installed in the AHU. And wherever it's not possible or you don't have an AHU, should have the UV lights in the operation theatre itself, so that overnight at the end of the surgery, you still have that sterility. all our staff use an N95. So we have compulsory N95, no surgical mask. The patient wears the surgical mask, but all the staff wear an N95. And we have the cycle of using it four times. So they use it for a day, then keep it in a sterile condition and use it after the fourth day. And after 4 such cycles, they dispose that off. We have our anesthetists have designed a suction tube kind of thing, which is usually kept near the patient's mouth or near the nose itself. So there is a positive suction that's going on, which is a mild suction. It's not a very strong suction there. So whatever the patient exhales is kind of taken into the tube, and then we have given the outlet at the return air duct. So it kind of trying to reduce the air being expired by the patient, contaminating the operation theatre. As a policy for surgeries which are of more than half an hour duration, so oculoplasty, complex retinal cases, we still do an RT-PCR even now. But for cataract surgeries, we don't insist on an RT-PCR unless there is something which is a concern for our physicians. So if the patient has a positive history, recent travels, international travel, or they have an influenza-like illness, then we do an RT-PCR. Other than these are some of the protocols that we are still following. Dr. Ravindra?
Yeah, for us, we are doing RT-PCR in all the cases which we are operating, even now, even for cataracts and for all other cases. Sir.
Yeah, we do an RT-PCR or at least an antigen test. Some people who do not want to go to the hospital for that swab taking, for them we do an antigen in-house also, it can be done. But there's some coverage is there, but we want to remove it, but we were worried about the third wave that everybody is talking about. So we are a little cautious on it. About the operation theatre, we used to clean all instruments with sodium hypochlorite, which I've just told you we have stopped it, discontinued. But we do use detergent, mild detergent to clean the instruments before the staff actually handles them. I personally have never used N95. I've always used surgical mask, but I tape all the 4 sides with transport tape so that I breathe through the surgical mask. I used to use single surgical mask, two surgical masks, but I use single right now. Much relaxed than before, but that vacuum thing which is there, what Dr. Girish Rao explained, that's in-house built pipe which is attached to the return air duct, which sucks actively the exhaled air of the. All our staff have got 2 vaccinations, and the cleaning is little more strict. Every 1 hour the floor is cleaned, and we put on UV light. See, COVID virus is very sensitive for UV light. It is said that in 3 minutes it gets killed. Okay, so we do have a UV light stand there in between. After 2 cases, we put on UV light for about 3-4 minutes, and then we enter into the operation theatre. So these are some of the changes that are persisting. We are diluted a lot from the time of peak of COVID era.
Yeah, during peak COVID, we used to have a gap of about 20 minutes between the cases. All those things have gone, and of course there was the guidelines was that the floor mopping has to be done every 2 hours with sodium hypochlorite. So now we have come down to some kind of a settlement and some kind of a midway wherein we are still taking precautions using N95 and all that. But yes, things have eased out quite a lot.
But my concern about the UV light as well as sodium hypochlorite, we vigorously used to mop with sodium hypochlorite. We lost a lot of valuable material in the operation theatre because it's highly toxic, corrosive to stainless.
Very corrosive.
It corrosive to the wheels of the, all the wheels got worn off. The trolleys and the OD table had to rechange all these wheels because the rubber wheels get corroded by sodium hypochlorite. So we stopped using sodium hypochlorite now in the operation theatre, in the cleaning protocols of operation. Stainless steel gets corroded. In fact, we kept one surgical set in sodium hypochlorite. the nurse forgot to take it out after 5 minutes. All the instruments got corroded. We couldn't use them. So it's a highly corrosive, in concentration of not 0.5 that's recommended. In concentration of 0.1% also it's very corrosive.
In
So-
fact, Ravindra, when you were presenting, you had shown sodium hypochlorite being used on your surgical instrument. I put a note there in one of the questions, in a long list of questions that I have for you all. It immediately came to my mind because we in our setup have lost a lot of
instrument.
steel furniture has been wasted, surgical instruments have been wasted. As you said, a lot of trolley wheels have been spoiled. So we have learned our lesson not to be too aggressive with sodium hypochlorite, though we still use it in our OT to clean the walls and the floors once in 2 days.
Okay, that's good. So I looked into it. Like food industry, the dilution is 0.02, not 0.02%. It's very diluted. So I used to use 0.01% sodium hypochlorite for surgical instruments. We used to dip only for 3 minutes and take it out. My surgical instruments were saved except the unfortunate accident. But the rubber tires had a big rubber instruments, for example. There's like, for example, the Leica microscope has got a hydraulic, like spring that got corroded. I had to replace the whole hydraulic spring of Leica. So one has to be careful with sodium hypochlorite. Though at that time it was essential, there's no other go. Either you stop doing surgery or you take full precautions. Sodium hypochlorite was the one which was strongly recommended by everybody. All specialists recommended that. So we lost something, but I think that's a part of give and take.
So there's a question on similar lines that, what anti-rust solution you use?
Anti-rust. Yeah,
Anti-rust.
it's called milk actually. 3M company has got, a lot of companies have got it. And the secondary has got anti-rust instruments. And we dip it and then it goes to the ultrasound, then it goes to the manual, the 4 steps of cleaning. And I don't remember the name, but it's available in all big companies. 3M has got a very good milk solution, but then you don't use it at the concentration they would recommend because our instruments don't get sterile. The worst thing that you can do to spoil our instruments is storing them wet. Storing them wet does 2 things. So that's why the moment it gets into cleaning, and we autoclave it. We autoclave it on the same day. Even if there is no surgery on the next day, we autoclave it so that at least instruments are preserved dry. Dry instrument will minimize for example, you have a scissors, for example, you wash it and you wipe it. When you wipe it, the external surface may be getting dried, but inside the crevice, it's still wet. Where their bacteria will multiply. One bacteria, I think I've got some numbers, can become a lakh of bacteria overnight, 1 lakh. And tomorrow you want to autoclave it and all the protein residue of the organisms will remain on it and it will cause TARS. In our OT, we have no infection, no TARS for decades, nothing, zero TARS rate, 0 infection rate. It's possible to achieve it if you do in a proper, monitoring of your operation theater. You don't have to worry about TARS at all.
So Dr. Shobit wants to know that do you autoclave visco also?
I autoclave visco from all the time. I buy the vials, we autoclave it. It's a part of the set. All medicines that we use during the surgery is autoclaved. Sometimes, Pilocar, for example, adrenaline, for example, it's not on the set, but it is kept as a sterile instrument. Just like we keep sterile instrument in a Tyvek pouch, I keep it and we open it and the ampoule is taken on the table and the loading is done by the nurse. And normally what they do is they break the ampoule and they give the ampoule, somebody draws it out. While breaking, 1 out of 10 ampoules, this is what I did study, had a glass splinter inside. That means that solution is unsterile. So I solved it by shifting it to the trolley and considering it as an instrument. So if I want pilocarpine or adrenaline injection for that matter, the whole ampoule comes on the table and the nurse actually breaks it. And one trick is it's very difficult to break it on the table. We don't have a saw there. So they partially saw it and then they autoclave it. So it's easy to break it with the hand.
If I take it further, what are the pros and cons of autoclaving these sterile gowns that we use and as well as BSS bottles, if it's in glass or autoclavable plastic bottles?
BSS, if you buy it from a known company, there's no need for autoclaving it.
I learned my lesson. I don't want to take names. MNC company, which comes in pouches of BSS, and you know what I mean. I have seen fungal growth in them. So I'm very worried on.
Yeah, there's a long discussion can happen on this. This contamination of the BSS occurs not while manufacturing it. I would I would endorse the manufacturing processes. Even India, I visited them. They have got very strict protocols of manufacturing. As it's manufactured, they are sterile. Most of the contamination occurs on the transit, and they load boxes and boxes. The lowermost boxes will bear the brunt of it, and they can open up. And the glass bottles of BSS, when the whole crate is put down on the floor, from the lorry, they put it on the floor. And there's such a vibration that the weakest part of the bottle, you mentioned about plastic, but the weakest part of the bottle is the bottom. It's convex below, and it can have a micro crack. And the contamination occurs during transit. I mean, you are right. When the contamination occurs, you have no control on how the contamination and storage is done. But sterilizing BSS in our hospital will not sterilize it again. How does it get sterile? They've got a separate process of doing it. We cannot emulate them in our operation theaters. So I have not autoclaved it any times, and I have nothing to regret. But inspection of it, as you said rightly, you saw the fungus. Inspection of it, two ways. Don't shake the bottle. Shaking the bottle will generate a lot of bubbles. Take it quietly and see the light through it, and in reflected light, both of them you see it. Then if it is clear, you're sure that no, it's sterile. I've never had to repent on it.
What about these disposable gowns? They already come sealed and so-called sterile. I in my OT, we have them autoclaved before it comes to me.
That's one reason why we autoclave I continue to use clothes, except the final wrap. Final wrap on the patient is disposable. Otherwise, I don't use any disposables. Our load of disposables at the end of the day, see 100 operations, we must be doing thousands of operations. How much of disposables we discard? We can't reuse them. So I've tried doing all these disposables, and I've gone back to the cloth ones, linen ones, and we don't touch our linen at all. And of course, cloth is porous, but as long as it's dry, it's a good barrier. But if it becomes wet, like in a surgeon's there you will have to be very conscious of any wet cloth transmit bacteria to go through it. So as long as you keep it dry, it's sterile.
Dr. Rao and Dr. Ravindra, so what is the take-home message for our audience? Is it advisable, or what are the pros and cons of actually autoclaving these sterile gowns so-called sterile gowns that we use?
Dr. Girish Rao has to advise.
So, I think we have gone through the whole cycle. We, for a cost factor, we went back to the linen. Then we had linen, those fibers which we saw in the sit lamp. Because sometimes, though we say we don't touch the linen and whatever, but there is always that possibility of this linen. And it's not a good sight to see on a sit lamp. You have this thread in the anterior chamber or stuck to the section and things. And obviously, as I said, you always have to depend on somebody else, or you have to have your own laundry to take care of all of this. So we have gone through that cycle, and we have now come to the disposable, and we are kind of quite comfortable with that. We have not had issues with the sterility part of it. So they do come in sterile packs, and one way of checking the sterility is to just see whether when you press on it, it's airtight. So I think that, and most of these also have their indicators. So obviously, you need to buy it from a standard company which fulfills all these parameters. I completely agree that there is a cost factor to it, but I think it's a small cost to pay for a person, for a patient who is undergoing a surgery only once in his lifetime, hopefully for a cataract, that kind of surgery. So I wouldn't mind having that factor. But if someone is able to ensure that the linen is kept as dry as possible, as what Dr. Ravindran was insisting on, linen is also acceptable. It's one way of reducing the cost and maybe even the greenhouse effect, but it requires a lot of
Girish,
diligence.
the key in the question was not linen versus disposable gown. What I was trying to get to is, are there any cons in getting our disposable gowns autoclaved before re-autoclaving or autoclaving them before using them? I'm not trying to, there's no comparison between linen and the disposable gown. What I'm trying to ask is very simple.
Yeah, so if I were to consider re-sterilizing it, I would do an ETO sterilize for these.
And why so? Why ETO and not an autoclave?
I don't want to expose it again to the steam and other things. So you just have this gas sterilization and then keep it. So it kind of is much easier to handle. Though obviously you'll need a much bigger ETO sterilizer to cater to the volume. And that's what I said. We in our hospital don't re-sterilize these bundles.
No, I'm not even questioning bringing in a
Yeah, I understand. I'm not talking about reuse. I'm saying even when it comes from the vendor, we don't subject it to one more round of sterilization before use.
Okay. The principle is the packing that the company has done is compatible for one kind of autoclaving and one kind of sterilization. So the general rule is that if you are using something which is sterilized by ETO, you should not do it on the autoclave. You have to go back to the ETO in case you have a doubt on it. So the packing, everything is designed for that kind of autoclaving, that kind of, sterilization. If the previously, most of the drapes are sterilized by ETO. So we'll have to go back to the ETO sterilization if you want to redo it. Or if you want to use the same pack for, for sterilizing it.
One thing Dr. Ravindra saw in your video was about packing of your surgical instruments. In a particular video that you actually showed us, there were about 6 to 8 layers of cloth, right? Now, the number of layers of cotton cloth that keep increasing impedes the amount of steam that's going to flow eventually to the surgical instrument, which is deep inside. So that is my concern, because
it's a B-class autoclave. That's what we do when we validate the autoclave. The autoclave process should be stronger. The size of it, there is a limited size. I think the weight of the pack should not be more than 5 kilos, if I remember it well. Size should be 18 inches, 12 inches, 5 inches, whatever it is. We should be within that. And any number of packs, the steam vacuum should be powerful enough, and the purging. It's the 4 or 5 times the steam is, it reaches the 20 pound pressure, then it goes to the negative side because all the steam is released. So it should be able to not only reach there, if there is a tube kept inside of the tube has to be sterile. So this is the autoclaving cycle, process cycle, and more number of layers should not deter from getting the depth of it sterilized.
There is actually a study which says that the increase in number of layers, despite it being vacuum, being used in a class B autoclave, does deter the steam actually flowing in and out of the instrument, especially in hollow instruments like phaco tubing.
Yeah. See, we have done the test. In the same packing, we put the process challenge device, which has got 1 meter tube to simulate the phaco tube of that diameter. It's kept inside. One end is open, other end is sealed, other end is airtight, and at the other end, the end of the tube, you put the indicator, PCD indicator. There's a special PCD indicator which is very, they have to go through the cycle completely to change the color. So all these are done by third party, not me, third party, and they say you're fine with the autoclave cycle. So any autoclave, when you buy it, do not use it immediately on the manufacturer's speculations or stipulations, and get it done. There are a lot of private agents who can do it. Go through them. They have their own machines, their own gadgets. They bring it, they load it, they challenge it the most critically, and then they give a report as to what you have to do, how to modulate your autoclave. And this is something which is very important.
What do you do for the patients? Like the question from Dr. Praveen Chandra, like for the patients, you just wash the gown and then they...
Okay. My patients, I thought a lot on it. What we practice in our hospital for almost 2 decades now is we give the patients to bring their own outside wearing clothes, and they're washed, they're ironed. We give a cover to them, a clean cover to them, so they are to put it inside and bring it here. Once they come here, they are put it in an UV chamber. UV chamber cannot penetrate inside. I know the depth of it will not be, and they will wear it just before they walk into the operation theater. So they are wearing dignified clothes. Many of the clothes that we give for them may not fit them. Somebody is obese, somebody is thin, and they may not obey them. So we have shifted over. We don't have to depend on it. And these are not sterile clothes. These are clean clothes taken care by the patient himself, washed and ironed, and they wear it inside the operation theater. And they can go out the same clothes because they belong to them. So this is something which we have been practicing it, and we are very happy with it.
We ask the patient to change into the disposable gowns, so male, female separate, and when they enter the change room, and then from there they are wheeled in, and they also wear the foot cover and the headgears and the mask. So at the end of the surgery, when they are wheeled out, they again get back to their street clothes and go back to the.
So these disposable gowns are sterile gowns?
These are not sterile.
These are not sterile.
These are not sterile. These are kind of packed and kept with us for a period of time before they are used. So in a sterile environment, but we don't sterilize it again.
So, Girish, what we get in our supplies is sterile gowns for the patients. So it depends on your supplier.
Yes.
It just has to be cured as you would do for the surgeon's gown.
Yes.
A very basic question has come up that, how do you ensure that the air that you use in the anterior chamber is sterile? So what method you use? Like, earlier we used to use those, lamps over which, the air was sucked in. Now we use filters. So what you people use?
Yeah. So if it's only an air, we use the millipore filter and then inject it. If it's a gas, then again, through the millipore filter, we take whatever gas, especially for the corneal surgeons, if they want to use it for their procedures.
Yes, most of us are using these filters only.
Yes.
Yeah, before AHU came, I used to do is, before you open it up, draw the syringe, draw the piston inside the cover itself. So presuming that the air inside the pouch is sterile, you just draw it. It's possible in ribbon syringes, then open it. It's already sucked air into it. So use that air.
Okay. There's a question about fumigation with formalin. Is it completely out of use?
Completely, 100%.
Completely out of use.
Same here.
Yeah. Then there's a question by Dr. Prathmesh. He wants to know that how about using glass as wall for operation theater? Any opinion on that?
I've seen glass being used. I think long back, I had seen one hospital in Agra where they used glass bricks jointed by silicon sealant. And the glass can be utilized, but what about the breakage? In case your trolley hits it, it can have a crack. So, but glass is a very elegant material to use as a wall, But then I'm worried about the space between the glass and the wall. How do you close the space? There is a space, potential space between them, and that's the one which can have fungus in it. So that's considering all that, I just had floor to ceiling vitrified tiles with spacing. That's how I planned my operation theater when I built it.
There's no wall. Yeah, so one way of elegantly designing it is to have an OT design out of glass itself. Yeah, but so the toughened glass, especially from standard companies like Saint-Gobain and all, can be used, but there is always that risk of developing cracks on hard impact. So that's, I think, the most absolute gold standard wall would be the SS, stainless steel 304 grade. That would probably be the gold standard for an operation theater if the purse allows.
There's a question from Dr. Pradeep. He wants to know that instruments cleaning by wearing surgical gloves, is it safe for staff? So wearing surgical gloves And cleaning the instruments, is it safe for staff?
It's certainly not safe if they handle it soon after surgery. But then that's why we put it in solutions to disinfect them in case there is a HIV or a hepatitis virus. They get killed by that. By the time the instruments come to the staff. And we still use sodium hypochlorite in such patients, a known HIV or HBsAg positive patients, HIV, even corona patients. A lot of corona patients are getting operated now. For some reason, we put them for 3 minutes or 4 minutes of sodium hypochlorite, 0.1%. The recommended is 0.5, but 0.1 also can kill viruses. So we keep it for 3 or 4 minutes, then only they are allowed to be handled.
Rajiv here.
Yeah. What about soap solutions? I mean, they even are very effective against viruses. So why go for sodium hypochlorite once we know it damages the coating of instruments?
Very good question, but soap has to be kept for a longer time. That's longer time. And soap residue, the problem with soap is soap residue. So you eat something and you wash your hands thoroughly and the soap and taste it, it still stays of soap. And getting rid of the soap from the instruments is extremely difficult, the soap that you want to use it. So if you are sure that your washing cycles can handle this residue of soap, it's a very good alternative to sodium hypochlorite.
Second thing is, I noticed in one of your videos is that you are writing down expiry date post autoclave. Now, how does one calibrate expiry date? What are the criteria? Is it as you said, the humidity levels, or is it the type of instrument inside? What are we talking about?
You answered it. Basically, it is the way how clean is the operation that it has to be decided by your own OT. If it's ideal conditions, like in a dry area, temperature is maintained, it's conducive for the growth of bacteria and fungi there, spores, all that has to be. If the expiry date is 1 year, okay, but then it's very difficult to create this. There are boxes available. There are big chambers available, which is air conditioned inside, where there is a AHU like environment inside. There is UV lights inside. The humidity is maintained at 40 or 50, whatever is ideal, and there you can keep it for any length of time. But this has to be, as you rightly said, depending upon your OT conditions, where it is stored, who is going to handle it. So, like for example, if you're storing in a place where you go washing instruments, there is a mist of water coming out that goes and settles on your instrument pack, and that is unsterile in next day. You don't have to wait for a week's time. So basically, in our OT, we keep 2 days as for autoclaves, and if it is kept inside the autoclave, if nobody has removed.
This we are talking about with pouches or without pouches?
No, the packs I'm telling you about. It's same philosophy applies. Pouch has got a paper on one side and a plastic on the other side. The paper is supposed to be water repellent. It is not water resistant. So if you keep that paper, you do the experiment. Whenever you buy it, what we do is in a pouch, I put water and hang it there. The pouch is of good quality. It takes 3 or 4 hours for the paper to get wet. But there are substandard paper available in the market, which the moment you put it in half an hour, it's wet, it's leaking. So we'll have to devise a lot of tests, our own tests to find out find out if a particular product that you're using is good or bad.
Another thing is that I saw one of your videos where you were sealing the pouches. Your OT technician was sealing the pouches, and what we do is we always do a double seal on each side, if not a triple one, if you're not sure, because there are instances that it might not be airtight. There might be wrinkles below.
Correct.
So
Yes,
we always double seal as a standard, if not a third seal.
Yeah, you are right. We do double sealing now. This must be almost 10-year-old video. And I just picked up because Rajesh said, I want to see what exactly you do. Many other very old videos. So double sealing is a must.
And what about people who, we are talking about the masses, everybody is not MS Ravindra. If somebody doesn't have a class B autoclave with a vacuum, what would you recommend? It's not that everybody can afford it.
I will not buy my car. I will actually sell my car and buy a class B. There's no alternative to it. It has to be a class B autoclave. It has to be horizontal autoclave with automatic control of the the steps. And see, Indian one costs 4 lakhs. Who doesn't have 4 lakhs rupees? I mean, it's an excuse. You don't buy a phaco machine, do an SICS and buy your autoclave. You don't have to buy a fancy imported autoclave. Excellent Indian autoclaves are available. There is no
Yes.
shortcut to B-class autoclave.
No doubt, you're absolutely right. But then would look at a class B autoclave of maybe 50 liters or 65 liters. That doesn't come in 4 lakhs. That's in double digit.
No,
lakhs.
Indians are quite cheap. You see,
But I have done a little research on this, and they say it's class B, but when you do I think it's called a helix test or a double helix test.
double helix test.
Yeah, double helix test. They fail it. They fail it most of the
No,
time.
see that there is a quality. You refine your surgical technique so well, you give so much of importance to your surgical skills. I mean, 1/10 of it you give it to selection of autoclave. There are excellent autoclaves made in India. You don't have to get fancy autoclaves. Their service is excellent. Delhi has a lot of good manufacturers. I mean, I think we should not shortcut, doing excellent things. No, I won't say excellent. These are standard things to be done.
Absolutely. Completely agreed, sir, because, safety is first, and whatever technique we do, we should try to, keep the safety of the patient in mind. And
It's all or none. A patient loses the eye,
Absolutely.
and where is the question of saving you 4 lakhs or 5 lakhs or even 6 lakhs?
True.
Any
And
amount of money will not get that.
spending on equipments which are costly, but not spending on, autoclave is, I guess, not a wise decision. Dr. Rishi, you would like to say anything? Dr. Rishi?
You're muted.
I've just been a mute spectator and listening to very interesting discussions, both by Dr. Girish and Dr. Ravindra, giving us real gems and just letting them sink in. And I was I joined in when that discussion on the mask was going on. And I was thinking, we double mask, but in the end, the air is going around the mask. It's not going through it. So the purpose of the mask is lost unless you actually tape it down. So our protocol in the OT, it's taped here, it's taped here, and it's taped here. Then you are breathing through it. Otherwise, you're breathing around it. Whatever does it make, whether you're wearing 1 layer, 2 layer, 3 ply, 6 ply, N95, none of that makes any sense if you're allowing air to flow around its sides. So I think that was one point that I thought, especially during COVID times. I mean, we've been wearing masks for years, but we've never actually taped it down. We used to use a top tape to prevent it from fogging the optics of either the microscope or the glasses that one is wearing. But one wasn't protecting ourselves from this aerosol-based virus. But I think in these times, at least over the last year and a half, that is the one thing that we have added to our mask use. With regards to the theater specifications and all, I was in complete agreement with Dr. Rao on the chamfered edges, and there should be no right angles and the tiles and so on. My own theater, which is a near class 100, has a window. It's a double window with that that blind that can actually so it's about that fat, and there's this blind running in the middle, but it's completely hermetically sealed with vacuum on the inside, and then where it's fitted into the steel of the operation theater, it's kind of, there's no breach there, and the window is protected on the outside, so there is no direct water or sunlight on it. So that's the only thing that I thought I would like to add. So excellent gems on the autoclave as well. I mean, years and years and years ago, that was the one thing I absolutely did not want to make any compromise on. So I got the most expensive horizontal Indian autoclave I could get, and it's in a different room because it generates so much heat. People will put it and not realize that you need 3 tons of air conditioning to take care of a 5 kilowatt autoclave. Which runs on 3-phase electricity, generates so much heat. So we created a special area that was bordering on the outside of the building so that the heat could exhaust out from there. So just a few tips. I think if you're planning things initially, they're relatively easier to do. The problem is, as guidelines change, retrofitting is a problem. And that is something that sometimes even I wonder, when the NABH came, they wanted an additional barrier to be put in front of what I already thought were adequate barriers. So I had to then create another little ante-room area with extra sliding doors and so on. The one question that I wanted to actually ask, I don't know if it was covered because I missed the main presentation, was the difference between a sliding door and a regular swing door in the main entry to the theater. Does that make a huge difference? Because we now have these positive pressure little instruments, and that needle is always showing a positive pressure, but that only works as long as it's a sliding door. If it's a swing door, it'll never work. Any comments on that, Dr. Ravindra or Dr. Girish?
The sliding door is a good concept because you don't increase or decrease it. There is no vacuuming and pressurization, but sealing a sliding door is difficult. I do not know how do you seal the sliding door because
no, it comes down.
Comes down, fine.
Yes,
if it comes down and seals it hermetically, then it's fine. It's expensive.
Yeah, it's very
a lot, but then that's a good option.
It's as expensive as the autoclave.
Yes.
Just the door.
I also agree, as long as it seals hermetically and is airtight, whether it's sliding or swing open, depending on the space availability, I think it shouldn't make a difference.
What is important is once the surgery is started, you ensure that nobody opens the door. So that's something, it creates eddies there. Of course, with the today's excellent AHUs, with the laminar flow, the eddies are least. The air flows directly on the entire operation theater, the 6 feet by 8 feet or whatever it is. Air is continuously flowing down. So the effect of eddies is not there, but you lose the positive pressure inside the OT the moment you open the door.
So that was really wonderful, sir. A lot of messages have come up that this talk was very useful and wonderful discussion that you did, and wonderful discussion by Dr. Rao. So people have thanked for this informative webinar. It was very interactive. So we would also like to thank both Dr. Ravindra and Dr. Rao for sparing their valuable time. Is Tityal sir around? Tityal sir, are you there?
He's here, yeah.
Sir.
Just come back, Rajesh.
Yes, sir.
I could listen to all the discussion, both of them. It
Yes,
was
sir.
wonderful. There's so much of learning, each step it is, it's a real learning for us. And we know that how RP Center works, and a lot of loopholes, deficiencies. And I think we are not accredited in that way also. But yes, I think we need to do a lot of work, and I hope the people who are logging today, they'll learn so many things. These things are never taught to our people, the basics. As rightly pointed out by Dr. Ravindran, the surgery, we think so much, I do this, my technique, but basic aspects are missing. Who will give us those, tips? And this was a wonderful, Rajesh. I'm pretty sure this particular session will be viewed by, large number of people in future also. And
Yes,
you must have, inputs from various other people also. And make we can circulate this particular session to various people.
Definitely, sir. The YouTube and also on the website of ISCRS.
Yeah, wonderful.
Thank you, sir. Ritika, anything you want to say?
So I personally think that we are also getting a lot of confusion with the COVID protocols, and now that they're sorted out, and hypochlorite, like rightly pointed out, has caused a lot of damage. Also that we are seeing some cases which have more reaction. I do not know whether it is post-COVID, there is a change in the blood aqueous barrier. So we've had a few cases of TAS, and I do think that what sir has pointed out, to store things for 2 weeks and identify batches, each surgeon should develop a protocol for end-off and TAS, and that is something that we have seen a slight increase in TAS. in COVID or whether it is the consumable. I don't know whether other people have observed it, because uveitis has also been reported late of COVID. I just wanted the comment if somebody has observed.
No, neither TAS, not endophthalmitis, not uveitis we have seen in our patients. We have gone back to the earlier numbers, and our it's zero. TAS is zero. TAS is easily identifiable. Most of the time, you walk through you take a videograph of. I've got a videograph of you ask somebody, or you best is you do it yourself. You go through the cycle, entire cycle. TAS most of the time is because of there are two reasons: the chemicals on the residues on the instruments.
Yes.
The second is they keep storing the instruments wet overnight and autoclaving it next time. You will have millions, billions of bacteria on the instrument. So one thing is never store anything wet at night time. And at the end of the day, every instrument that is in the operation theater has to be dry. That will minimize or avoid TAS happening. These are the only two factors. So
another question I had was that now there are just no recommendations of surface culture to be taken. It's only air culture. Yet a lot of the ophthalmologists continue to take surface culture, and so do we. But some guidelines are now saying that only air culture is required. So what is your recommendation for surface and air?
OT protocol wise, there is no role of routine cultures in the operation theater. There is no role. No, this nobody may agree on it, but actually taking culture, I can't understand that how you take culture from the wall and it becomes sterile, how a wall can be sterile, how a floor can be sterile. You take a swab from your footwear tomorrow, put it in culture medium, it becomes negative. How can you believe it? It's not possible to believe it. And if it comes negative, there can be contamination there. So taking precautions, and of course, NABH says, and legally, if there is a problem, they'll ask, where are your questions? For that reason, you take cultures, but don't trust them. You trust your people, trust your surface cleaning, which is much more important than these protocols. And
so
there are a lot of gadgets available.
Or surface culture as plus air culture?
Both need to be taken, madam. NABH wants both to be taken.
Right, sir.
And the air culture, static air cultures are of no use. 1 hour air cultures are of, like sedimentation cultures are of no use. It has to be minimum 3 hours. 3 hours is the subtle plate method, whatever you call, you keep it there and let it that's 3 hours is the minimum. 1 hour, we all do 1 hour. That's an eye wash.
Right. Thank you, sir.
Thank you, sir.
Thank you,
so it was a wonderful talk and wonderful discussion. So a big thanks to both of you, to Ravindra sir and Dr. Rao sir. Both of you have been excellent, and of course it was a wonderful discussion. A lot of things to be learned from this, and this presentation and the whole discussion will be there on YouTube, as well as it will be uploaded on the website of ISCRS. So big thanks to all of you. A big thanks to all the panelists, our president sir, and Dr. Namrata, Dr. Ritika, Dr. Rajiv, Dr. Rishi, and of course our staff, the IT team, Bageshwar, Anil, and also a thanks to IPCA who have supported this webinar. So thank you all, and a very good night to all of you.
Thank you, Rajesh. Thanks for giving us the privilege.
Take care.
Bye.
Thanks.